Good morning, good afternoon, and good evening. On behalf of University of North Carolina at Chapel Hill and USAID Advancing Nutrition, we'd like to thank you for joining us today for the FIND COP, or the Family Inclusion in Nutrition Through Engagement Community Practice. My name is Neha Jabari. I'm a social and behavior change specialist with USAID Advancing Nutrition. Please go ahead and do introduce yourself in the chat. It seems like this morning maybe everyone knows each other. So today's session will be focused on family dynamics, mental health, and nutrition. Before we get started, I would just like to share a reminder that if you would like to learn more about the FIND COP or would like to access the recordings from earlier this year as well as last year, you can do so by accessing our webpage, which I can share in the chat. And I would also like to note that USAID Advancing Nutrition is coming to an end, and UNC will be continuing the FIND COP. And these recordings that are currently on this webpage, as well as future recordings, will be on a webpage through UNC, and we'll share those UNC transition updates through the FIND COP listserv. You can receive, if you are not part of the FIND COP listserv currently, you can either do so by indicating interest at the time you register for the next meeting, or you can respond to the Zoom confirmation there's an email included there for any questions, and you can let us know that you're interested in joining the listserv, and we'll be happy to add you. So we'll start off today's meeting with a presentation on family dynamics, mental health, and nutrition, where we'll hear about work in Pakistan focused on mother-in-law caregiving and perinatal depression in rural Pakistan. Then we'll have time for questions on the presentation before moving to some small group discussions. And then we will wrap up for today. So before we move into the presentation, I just want to take a few minutes to reiterate that we often turn our attention towards nutrition, but this is an opportunity to broaden our thinking and to remind us that nurturing care is made up of these 5 components. Early child learning, opportunities for early child learning, responsive caregiving, safety and security, in addition to good health and adequate nutrition. During today's meeting, that will also thematically center around mental health and early child development. We are interested in hearing about your experiences as it relates to nutrition and nurturing care overall. As grandmother roles, as you may all well know, as well as other family members, help contribute to each of these components. And we will hear more about this in the presentation and likely during the small group discussions as well. I would now like to introduce our speakers for today. Dr. Siham Sikander is a psychiatrist and a global mental health academic. His focus is on developing and evaluating task-shifted, non-specialist-led, health systems-focused maternal mental health and child development interventions in low-resource settings. As a public mental health academic, he works closely with the policy and practice environment of Pakistan and collaborates with the Ministry of National Health Services in Pakistan. Dr. Sikander holds dual affiliations, one at the University of Liverpool at the Department of Primary Care and Mental Health in the UK, the other at the Human Development Research Foundation in Pakistan. Next, we have Dr. Esther Chung, who is a social epidemiologist at RTI International, a nonprofit research institute. She has over 10 years of experience conducting public health research in global and domestic settings, with a focus on understanding how social environments and behaviors influence population health disparities, particularly among underserved populations. Her research experience includes studies of early child development, maternal and child health, mental health, health equity, randomized trials, and intervention and evaluations. Her dissertation used mixed methods to explore grandmother caregiving, family dynamics, and child development in rural Pakistan. And then we have Dr. Natalia Concha, who we're so fortunate to have facilitating the Q&A today. She is a qualitative research fellow working in the food and healthy weight theme at ActEarly, based at the Center for Primary Care, Wolfson Institute of Population Health at Queen Mary University of London. Natalia completed her PhD in social health in social psychology at the London School of Economics, where she explored family community and the institutional resources impacting maternal and infant health in Colombia. Prior to joining ActEarly, she worked as a postdoctoral research officer at the Department of Psychological and Behavioral Science at LSE, where she continues her collaboration as a visiting fellow. She has worked in qualitative and evaluation research with El Colegio de Mexico and Colombian public health institutions. Prior to embarking on her PhD, she worked in the UK policy-based research on health promotion, diversity and inclusion programs for UK government departments, local authorities, and charities. Her research interests focus on sociocultural psychology, maternal and child health, family dynamics, youth development under contextual adversity, women's reproductive health. She's also a member of our steering committee for the FIND COP, so we're very happy to have her here today. And without further ado, I will now turn it over to our presenters, Siham and Esther, and thank you once again for joining us. Over to you both.
Thanks, Neha, for the introduction. And once again, thank you very much for inviting us to talk about our work and be part of this session. The way that we will go about is Esther very kindly, my dear colleague, will be sharing some slides, and she'll walk you through with the work around family engagement, especially grandmothers, how they feature in caregiving practices. But I will very briefly, I don't have any set of slides. I will just very briefly give you an overview of maternal mental health, especially from both the global perspective and very quickly from the perspective of Pakistan, and the kind of psychosocial interventions that we've been doing in Pakistan, and trying to not only address maternal mental health, but also promote early childhood development and nutrition and socio-emotional development of children. So you may be familiar with the term perinatal depression, or synonymously also known as maternal depression. This is, it's by far one of the most common conditions that around 32 to 35% of women experience, either during pregnancy or within the first 2 years postnatally within low resource settings. This is nearly double the burden what women in high income country settings face. There are numerous systematic reviews which provide this burden and the prevalence. In terms of why is it important? Because in many settings, especially low-income settings, mothers are the primary caregiver. And maternal depression or perinatal depression has been associated as an independent risk factor for you name any child outcomes, starting from intrauterine growth retardation to stunting within the first 5 years. And you may be familiar with the fairly recent publication of Dr. Maureen Black in terms of taking a life course approach where maternal depression and poor mental health of the mothers feature heavily in the developmental outcomes of children. And there are numerous studies which, as a developmental outcome, maternal depression is a risk factor to their growth, not only physical, but socio-emotional as well as cognitive development. Now, in terms of how to tackle this in Pakistan, we've been developing interventions delivered through non-specialists, because you may also know that a majority of the population globally lives in an area where there will be less than one psychiatrist for a population of 200,000. So specialists will never be able to address maternal depression or mental health conditions. So we've been task shifting or task sharing, developing interventions, very family oriented, because in the settings that we work, mothers or women many a times are not the only decision makers in the house. So you need to engage the families. And Esther will be talking about an ongoing cohort study in which we embedded an intervention not only to treat depression, but also to enhance child development, early childhood development. We've done a number of trials in Pakistan as well as in India, trying to address and integrate addressing maternal mental health as well as trying to improve child nutrition, development, social, emotional, as well as physical outcomes. We recently published a large trial, both from India and Pakistan, that was about ECD, adapted version of the UNICEF and WHO's Care for Development package, delivered through community health workers in India and in Pakistan. Whereas Esther will be talking about an ongoing study in Pakistan, the Bachpan cohort, where we used peers to not only address depression, but also to promote early childhood development. And we saw lots of family engagement and grandmothers also being involved in that. So I'll take a pause here. Any follow-up questions or any comments, we'll be happy to take them in the Q&A session. So thank you very much for your attention. Back to you, Neha, and rather Esther, for your set of slides. Thank you.
Great. Thanks, Siham, for setting that context. Let me see if this will work. We'll share my screen. Okay, so yes, thank you again for allowing us into this space to talk about some of the work that we've been doing in Pakistan. I will be talking about a paper that we published looking at specifically mother-in-law caregiving and perinatal depression in rural Pakistan. So to set some background, in this space, I don't think I have to say that child rearing in many contexts around the world is a communal responsibility among many caregivers in the household. And in particular, we're focusing here on grandmothers. This was an interest of mine because I felt that they were sort of ignored or neglected caregiver to think about. And so in rural Pakistan, women typically will move into their husbands' homes, and so they will co-reside with their mother-in-law. And we were really interested, building on some prior work that we had done looking at grandmother caregiving and child development. We wanted to look at effects of grandmother caregiving on maternal mental health. And so looking at prior work, mother-in-law support may buffer against any perinatal depression through increased social support for women during the postnatal period. However, prior research has also found that it may lead to greater stress and worse mental health for mothers. Prior qualitative work in India and Nepal and in China have demonstrated really complex relationships between mothers-in-law and daughters-in-law, with mothers-in-law exerting profound influences on daughter-in-law's access to healthcare or reproductive decisions during the perinatal period. And oops, I think I skipped all of my things. So the other thing that we are cognizant of is the fact that general family conflict outside of the mother-in-law and daughter-in-law context is important to consider on the relationship between mother-in-law childcare and maternal depression in our context. And so these are other family dynamics that happen in households that may affect mom's mental health, as well as the extent to which a mother-in-law cares for children. And so we were interested in asking this question of how mother-in-law childcare can affect perinatal depression across these contexts of family conflict. So as Siham mentioned, the data that we used for this study came from the Bachpan cohort, Bachpan meaning childhood in Urdu. And this is a cohort study that has a birth cohort study, excuse me, that has an embedded perinatal depression psychosocial intervention that was built off of the Thinking Healthy program, the WHO mental health program. And we've been following mothers and children from the 3rd trimester of pregnancy through, at this point, Siham, I think we're starting the 8-year wave for children. So this study here, we're really just focusing in and narrowing in on the 1st year postpartum. However, we have been following mothers and children for a long period of time now. And so in this study, we were interested in looking at the 3-month and the 12-month time periods postpartum, looking at mom's depression and mother-in-law childcare, which we collected from maternal reports and sort of a 24-hour recall of caregiving activities that any family member was doing in the household. And more details you can find in the paper that we've published, but just a quick overview of the findings. So mother-in-law childcare was very common in the 1st year postpartum. Mothers-in-law were most commonly reported caring for the child when the mother was busy or unwell. And the second most common activity was playing with the child. Maternal depression decreased between pregnancy and the 1st year postpartum, with a prevalence at 12 months of roughly 16%. And then quick finding overview in the immediate postpartum period. So at the 3-month time point, we found that mother-in-law childcare was linked to a lower prevalence of maternal depression, underscoring the importance of social support in that first immediate period after pregnancy. But then towards the end of postpartum period, at the 12-month mark, mother-in-law support was no longer beneficial for perinatal depression in families without conflict. And actually, among families with reported conflict, high levels of mother-in-law support was actually associated with increased prevalence of maternal depression, again, at that last time point. And then just a quick statement, we in this study, underscoring that incorporating family members into caregiving interventions, nutrition interventions really requires careful consideration of the family dynamics of each context and managing conflict between caregivers in order to maximize these benefits for both children, mothers, and potentially even grandmothers. So I'll leave it at that. We can answer any questions in the Q&A portion. We wanted to leave a lot of time for that. But just a quick thank you to all the participants of the Bachpan cohort that have graciously allowed us into their homes for the last, 8 years, 10 years now it feels like. Our amazing team at HDRF, and then funding from NIMH and NICHD. And we're happy to take any questions now. I hand it over to Neha or Stephanie for monitoring. Or maybe I can just stop screen sharing and see everybody. That might be nice. Okay.
Thank you so much, Esther. That was wonderful. Thank you both, Siham and Esther. That was a wonderful presentation. You gave us a lot to think about, especially when it comes to specifically grandmother engagement. I will now turn it over to Natalia to facilitate the Q&A. And please feel free to share your questions over chat or come off of mute. And yeah, over to you, Natalia. Thank you once again for doing this part of the session.
Hello, everyone from different corners of the world. And I just want to say thank you very much, Neha and team, for having me here today to help facilitate the discussion stimulated by Siham's and Esther's work. It really is great to be here and share this space with you all. So first of all, thank you very much for sharing your research and the paper that you also emailed us earlier. I think it highlights the importance of maternal mental health, and you're focusing on maternal depression in the Pakistani context. And I think there's a lot that we can discuss and talk about this. So I'm going to kick off first the discussion and ask you a couple of questions, and then we'll open it up to any questions that any of you might have from the Q&A and the chat, as Neha just say. Okay, so your work, I think, uplifts the need to address maternal mental health, which I find so needed, because as we know, much of the focus of maternal and child nutrition and health programs remains to a large extent child-centric. But as many of us advocate, we cannot address the needs of the child if we don't open up the wider family system, and particularly give mothers that space to bring out their own subjectivities, and acknowledging that they're also, not the only ones in mothering. And I'm very pleased to hear that your work also includes paternal grandmothers and mothers-in-law and women. I would like to ask you how, first of all, how could we encourage more inclusion of maternal mental health in maternal child health and programs? I mean, there's a lot of focus on physical health, but mental health, of course, as your work shows, is vital. And then lagging on to that, you briefly mentioned, Siham, the peer work that you have been doing. So perhaps also, if you could share with us, what are some of the key components that you have seen in your work that may enable, that may facilitate that integration into these nutrition interventions?
Thank you, Natalia, for those very two important questions. But before I come in, I'll request Esther if she has any immediate thoughts about these. So otherwise, I can start off and she can jump in.
I will defer to you, Siham, because I feel like your wealth of knowledge here is going to be really interesting for everybody. Yeah, I want to highlight your work more. So go ahead.
Right, thank you. Firstly, I think, Natalia, the importance of maternal mental health is now just, in my opinion, I think less than a decade now, that maternal mental health has now gained traction. And I think through understanding that despite nutrition fortification, ECD-related materials, they didn't sort of provide the impacts. And it was understood slightly later that maternal mental health, primarily because of she being the primary caregiver, especially within the first 2 years, is critical. If she's not 100%, she's not at her fullest functionality, all the caregiving aspects, be it vaccination, be it feeding and child rearing, they all get affected. So, and thus there was a whole movement led by Maureen Black and colleagues to try and push, and people like Atif Rahman and myself and Vikram Patel, and trying to get the maternal mental health agenda, at times calling the missing M in MNCH. So, so all of that movement has, I think, culminated in at least acknowledging that maternal mental health seems to be at the center of any of the programs, be it vaccination, because she's the one, she's the first responder. So I think it's now well established. Now, how, after recognizing, I think that's the first step in many of the low-income country settings, as well as the ECD space, as well as the nurturing care framework has taken into that account. But how do you do that? That's the biggest challenge. How do you implement? And we've been trying to do that through a number of approaches. And at the heart, has been either through peers who are other mothers within the same communities, or the government employed community health workers trying to integrate these low intensity, psychosocial, very boiled down basic interventions, not only to support and treat maternal mental health issues, but also to help promote the early childhood development part by engaging families. So one of the key components, apart from maternal mental health, is the bonding aspect with the child, as well as engaging the family, because in her own capacity, she requires support from others. I'll give you a very quick example. In Pakistan, 85% of women early initiate breastfeeding. But by the second month postnatal, this 85% of early initiators falls to around 30% of breastfeeding. So why this massive drop of nearly 50% of moms dropping off breastfeeding? Because they are demanded to take up household chores. So the first thing that gets neglected is child-infant nutrition, breastfeeding. And in low-income country settings, that's key. WHO recommends 100% exclusive breastfeeding in the first 6 months. So I'm just saying that until and unless you don't engage the families, not only to psychoeducate them, but also to carve out some space for the moms. Otherwise, they'll be into their daily chores. She's the primary caregiver for the first, and the story goes on. So our interventions have always been heavily focused on family engagement. And now with Esther's work through the Bachpan cohort, we see that I think that's a missed opportunity for our interventions to not only have family engagement, but also to try and see other experienced elderly women within the household who often have lots of say, and lots of, at times, unwanted competition with the primary caregiver in decisions, when to feed, not to feed, how to wean, what to wean, etc., right? From very early on. So they can be reeled in. And I think one of the things that have helped us through the Bachpan cohort is identifying what enhancements can we make in our ongoing interventions. So I'll take a pause there. I hope that helps answer some of the questions that you asked.
Thank you very much. You also draw the importance of acknowledging the material conditions that basically might be limiting a lot of these families in the global south, and we need to also keep that in mind and not just think about like the psychosocial or the relational aspect, but also the heavy weight of the context that so many people live in the majority world in conditions of poverty and inequalities. There's a few questions that are coming in. I would love to continue, but I'm also very conscious that people have questions. Judy, earlier I saw that you had your hand up. Did you want to come in? Or otherwise I'll move on to some of the questions in the chat. You're on mute.
Okay, yeah. Yeah, Siham and Esther, thank you very much for what you shared. Yeah, I'm familiar with Esther's work, and also with the work of a nutrition colleague or Asim in Pakistan, whose work also in another area perhaps of Pakistan that has revealed the important role of grandmothers. I think what you've shared, it provides additional evidence as regards the limitations of the the Western nuclear family focus that excludes other influential, as you were just saying, Siham, actors within the family context. And I think as you were just mentioning, yeah, we talk about grandmothers or mother-in-laws, but I think as you were just saying, it's not one person, it's the social network of those normally older, experienced women who are advising, as you were saying, do this and don't do that. I think it's very important that you were mentioning that grandmother, as well Esther was mentioning, grandmother's social support in many cases is positive. In other cases, it could create conflict or even involve, perhaps proposing practices that are not optimal. And I just wanted to say, I think very often people will talk about grandmothers' bad practices as a justification for not involving them. And I think, as I see it, the concept of, or the importance of the grandmothers, it's not that everything that they are doing is positive, but rather that they have power and influence, and that being the reason for including them. And I think just lastly, I think so important at the initiation, at the outset, in terms of formative research, of not coming with preset ideas of who the key family actors and influencers are, and really mapping out, figuring out who is involved directly, indirectly. And I think up until now, very many programs and very many programs and many research, many articles, research articles, talking about the involvement, the importance of involving men, and indeed important for them to have greater knowledge of women's and children's needs. But I think seems to me often those kind of decisions are made based on more of a Western vantage point of how the family is structured, and really the importance initially of understanding in whatever context what's really going on, who's involved directly, indirectly. Thank you so much.
Come in.
Natalia, can I just quickly interject before you take further questions from the chat?
Mm-hmm.
Yes, please. Yes, please
just
come in and reply to Judy.
Yeah, thank you, Judy. I think that's a brilliant take and summary. Just to add 2 points for all the participants, and I'll be happy to share resources as well if you would like. We've been in the background. We did for a program. I was referring to the India and Pakistan, the Care for Development package. We adapted that WHO and UNICEF package and delivered it through community health workers, integrated into their routine work. So we understood from the formative phase that the communities, the moms, the households, the families around ECD practices, they knew a lot of things, which were through observation and through years of experience. So it was not that everything that they were doing was off the shelf detrimental. But what we understood, the take home, that there are numerous positive and good practices already within the communities. However, because of the primary caregiver being so stretched, that all of these practices do not culminate in a very focused, concerted way onto the child. So you have to broker some leeway for the moms to get supported by others. And of course, there will be some psychoeducation that will be required. I mean, I'm not the last word. There's new evidence coming up. So it's teamwork. So many a times our grandmoms would stop us in our tracks and say, "You're going to tell me I raised a family, right?" So we would say, "Of course, you've raised a family. You've done lovely. And we learn from you. And we'll also interject some new things that might be advantageous. See if they sound remotely impactful to you." So it's like creating some space for them to be heard, their authority not to be challenged, but working together. So I thought that I'd just interject that. Back to you, Natalia.
Yeah. Thank you.
Thank you so much. Judy, does that answer your comment and your question? Judy?
Sorry.
Okay.
Oh, sorry. What did you say? Sorry.
Can you hear me okay? I hope so.
Oh, I thought.
Yes, we can hear you.
Yes. Okay. I just wanted to check if you were happy with that with Siham's
Yeah.
response.
Yeah, great.
Okay.
Yeah, wonderful.
Okay.
Thank you. Yeah.
In the chat, Ashish, you had asked a question to Esther, which Esther, you have replied, but I'm wondering if you might want to come in and describe a little more how you categorization of the mother-in-law childcare engagement, Esther, for the wider group.
Sure. So Ashish asked a question about the comparison group for our analyses. And when we looked at the mother-in-law caregiving activities, we had a range of the number of activities that grandmothers were reported participating in. And so we made the decision, since no one else had really done this work before, we decided to make these categories just based on the data. And so there was three groups that we had: a 0 category for none, a low, which was 1 to 5 activities, and then a high group that was 6 or more. And so we compared the low and the high groups to the no involvement group. And I also put in the chat a link to the paper on using the same measure, but looking at early child development within that same period, and including a 24-month time point for socio-emotional health of the child. Yeah, I'll stop there.
Thank you very much, Esther. I think that really clarifies, and it's very interesting always to go back to understanding the methodology and how things have been operationalized. It really helps to ground the findings that you have reported. Kate, I saw that you had your hand up earlier. Do you want to come in and ask them a question?
Sure. Thanks so much. Thanks for a really interesting presentation, and also the papers have been really valuable. And I think it's great to have demonstrated how the perception of whether the help is positive or not depends on the relationships in the family, and also on the timing. And I was interested in the timing piece because it seems so relevant to nutrition, where we're starting out, grandmother's influence on whether someone initiates breastfeeding, whether they breastfeed exclusively, and then complementary feeding, the timing and all of that. And I think also timing would be very relevant for early child development outcomes. And so I have not read the paper on your outcomes, but given that you saw outcomes, I think it's like by the amount of mother-in-law care, I'm wondering if there was a way that you were able to measure the quality of that mother-in-law care, in terms of the impacts like what practices they were involved in around nutrition or child development. And I know that would be hard, but just wondering if you tackled that, and also any of your thoughts on dealing with the reverse causality issue here where more depressed mothers might lead to mother-in-laws being more involved versus the opposite situation. And given that you've been doing this over the long term, I'm wondering if you've been able to look at that. So thanks.
Yeah, thank you, Kate, for that question. There's two questions. So I think first, the piece about quality, so important, and we did not look at that. That was a limitation of our paper and our measure, but it was maternally reported. And so from our point of view, mothers in this setting being the primary caregiver, we felt that her reports of what mothers-in-law were doing was still valuable in terms of her own depression and her own mental health. But yes, quality of caregiving from both mothers, grandmothers, anyone is really important to capture for both child nutrition and child ECD. And then in terms of reverse causality, yes, this paper that was looking at maternal depression was cross-sectional analyses at both the 3-month and the 12-month time points. And so we are looking at associations here, but the other paper that I referenced in the chat does include some longitudinal analyses looking at grandmother caregiving and child development outcomes specifically. But we were hypothesizing that in the maternal mental health paper that the caregiving at 3 months and at 12 months are very different for mothers-in-law and the amount that she's giving, and that we felt that any sort of impact on maternal mental health would be more immediate rather than long-term in our setting. So that's why we only looked at the cross-sectional analyses there.
Right.
And then Siham, if you want to add anything. Oh, sorry, go ahead.
Yes. Kate, thank you very much for that important question. And in terms of the quality of assessing the caregiving quality, that's, I think, one of the tough ones to measure, the method around it. So any sort of guidance or any materials that you can link us up with, that'd be great. We have proxy measures, of course. For example, trying to understand the quality of interaction between the mom and the child. So we've adapted an approach where there is a actual observation of mom and child interacting over an activity, trying to gauge what the affect of the mom is, how irritated, intrusive, etc., how acknowledging, how withdrawn is she. So it'll be good to, I know the ECD literature, and I know the quality of, so for example, scaffolding. I'm sure you'd be familiar with scaffolding and how to observe that, but haven't come across ways to capture it as objectively as possible. So it always falls on some form of self-report or the other. So it'll be good for if you can link us with any of such materials, that'll be really helpful.
Just to thank you. Yeah, it is a tough one to measure. Just to clarify, when you ask the mothers to report their mother-in-law's care, is it just like hours a day, or do you say, do you feed the child? Does she bathe the child? Does she watch the child when I'm sleeping? Is it as specific as what she does?
So the measure was actually really unique in that it was sort of like a 24-hour recall, but we asked for the mom to report from her child's perspective who was involved in throughout the day in different caregiving. And so it was more trying to actually fill in some qualitative piece to this quantitative measure, but asking really in the morning, like, who was there when the child woke up, who was taking care of the child throughout the day, and these different activities. And then we sort of quantified what she was saying into these specific caregiving activities throughout the day of feeding, sleeping, soothing, a number of different activities.
Oh, that sounds like a better way to do it. Yeah, that's good. And as far as the quality of the nutrition care, I mean, the only thing I can think of off the top of my head is to interview or do a survey with the mother-in-law to find out what nutrition practices they support. So at least we know. I mean, there are often complaints that the mother-in-law interferes with the exclusive breastfeeding or something like that. But to at least get a sense of whether the mother-in-law is on board with the practices that we would recommend would be a first step. But yeah, besides observation, it's really tough to get at quality. Thanks so much. That's great to hear what you've been doing.
Thank you, Kate and Esther and Siham for that very stimulating discussion. I don't see any other questions in the chat or anyone having their hand up. So perhaps if I could come in and ask you if you could talk a little bit more about the nuanced understandings that you have found, perhaps drawing on your qualitative work on those maternal practices and how those dynamics are actually played out with the mothers-in-laws, and maybe ask you if you have explored whether there were other relationships, perhaps with the maternal grandmother or anyone else within the family system that might be supporting the mother and the child, and sort of to have a better understanding of how that network of support operates in your context.
Yeah, Siham, I'm happy to talk about this a little bit and then would love for your input. So this was actually some of the work I was doing for my dissertation, where we were looking at both mother and grandmother from the same household in the Bachpan cohort, and we conducted qualitative interviews. It was at the 6-year wave, so children are a little bit older. Mothers and grandmothers are a little bit older, but the mother was asked, so who is most involved in the child's life, either the paternal or the maternal grandmother. And then we tried to ask that grandmother to be involved in our study. And so we asked a number of questions about what each caregiver is doing, mother and grandmother. We focused on the mother and grandmother for this qualitative study, but we were able to gather more information from the grandmother perspective, which we had not been able to do before. And we also asked about their relationship and their dynamic, and then effects on children. And then we also have quantitative surveys on this point about the grandmother-mother relationship, which was only reported by mothers. And so what we're sort of finding from both the quantitative and the qualitative are that the relationship dynamic between mothers and grandmothers are really important, and can affect both maternal depression, maternal mental health, as well as engagement in childcare. From the qualitative interviews that we found, for the most part, mothers and grandmothers get along well. There's not much conflict. One of the things that we did find was that grandmothers typically had the last call, sort of the final decision in our context. And so on issues related to finances, to children's care, there was often involvement with the mother, but the mother would often defer to the grandmother for her decision, which I think is important for considering how decisions are made within the household for different childcare questions. And so, yeah, it was really interesting there that mothers and grandmothers got along very well. I think to Judy's point, yeah, we often hear that grandmothers might be interfering, having these bad decisions or bad outcomes for moms, but we found that they got along pretty well. And in sort of the most extreme cases, mothers and grandmothers got along really well. They felt it was very cooperative within that dyad. And then on the other hand, on the other extreme, in some cases, mothers would actually just move out of that joint family household to be a nuclear family because of some tension with the grandmother. But for the majority of our interviews, mothers and grandmothers were in the middle or on the sort of cooperative side. Siham, I don't know if you want to add anything more.
Thanks, Esther. And I think just to add, I'll come from the slightly more intervention side. I think two aspects are sort of beginning to at least inform us for our interventions. One is that we are now beginning to understand that the dynamics between the mother-in-laws and the moms also needs to feature quite centrally in our family engagement component of the intervention. How can we leverage her? How can we team her up on the side of the mom? She's already doing that, like Esther said, that most of the times they get along well. But there will be a substantial number of households where there are other adversities like intimate partner violence. They are special groups, subgroups that will require much more work and engagement. And these are the households which refuse to engage, change, get on board. I think the second component, the second aspect that we're beginning to understand is the missing voice of the fathers. And I think the family engagement component, at least of the interventions that we've been doing, haven't been that forthcoming in engaging the fathers, because we're dependent on, because within the settings that we work, these are women, either the community health workers or peers. So it's women-led interventions. And the minute we talk about men and women interacting, we face a challenge. So we need to bring another male mobilizer or psychoeducator or other. So we immediately start getting into complex domains, and but that's our set of challenges. But just highlighting that these two components are the missing things that we feel in our interventions. And we are trying to understand more and unpack more. We have another piece coming up for the Bachpan cohort where we will try and understand and engage men as well as other household members to try and understand their role, how gender plays up, girls growing up, boys growing up. So it's an ongoing cycle, because these girls will become moms at some point in time. So trying to look at the both ends of the cycle. But these are missing pieces in our interventions thus far. So I'll take a pause there.
Thank you very much, Esther and Siham. I agree with the wider engagement. I think we need a lot more analysis on the wider support systems that are happening within the family and beyond, because as we know, also many other communities, there are other people that provide that support that might not be necessarily blood related. So there's a lot to do with that. Agree about the grandmothers being untapped resources for our programs in terms of policy and practice, but it would be, of course, very interesting to explore more the work with engaging fathers. I think there's people in this group that have done work on that. There is, of course, a lot of challenges, big challenges brought in with the gender component, but also I think in many other situations and communities, like in my own work, grandmothers remain central scaffolding source because there is that absent dynamic with the fathers. I would love to continue talking to you all, but we've got 1 minute left, so I'm going to pass over to Neha to wrap up. Thank you so much. It's been a pleasure.
Wow, what a conversation. I think we've spanned many different areas of this research, as well as family dynamics, family engagement. Thank you so much, Natalia. That was a wonderful facilitation of this Q&A. Thank you, Siham and Esther. It was a wonderful opportunity to hear from you both and to explore this topic a bit further. It sounds like there's a lot more to say, a lot more like to continue on with this thinking. So please do take advantage of the Find COP listserv to share relevant resources. Please continue to access the webpage, and the recording of this presentation will also be up there shortly. Thank you all for joining us today. It's been lovely to have you all here, and we will update you soon on our next session. Thank you. Thank you once again.
Thank you very much, Neha. Thank you, Natalia, for your lovely interjection and facilitation. And thank you very much, everybody, for listening in patiently. Happy to answer or engage outside the session if you have any follow-up questions. Thanks, Neha, once more.
Thank you, everyone. It's been
Thank
wonderful to
you.
be here.
Bye, everyone.
Thank you so
Everyone,
much.
have a good rest of the day. Thank you.
You too,
Bye.
Neha. Thank you.
Okay.
Bye.